Welcome. Wow, the operating room? Alright, from here on, I'll walk you through the instruments I actually use during surgery, one by one. First, here's a disposable surgical drape. When we're preparing for surgery, we disinfect the patient and then cover them with a clean, sterile drape, because we can't let anything get contaminated. This drape is disposable, so we use it once and throw it away. It's made of the same material as the disposable gowns that I and the nurses wear. You may have seen the green fabric ones too. Those can be washed, sterilized, and reused, whereas this one is disposable, so it's used once and discarded. During surgery, we keep rinsing with saline or liquids like betadine, and if the drape gets soaked with that fluid, there's a risk of contamination. So when we use this disposable one, it's waterproof, so it doesn't get soaked, the liquid runs right off, and that helps minimize contamination. Especially because operating while something is damp and soggy is not only a contamination issue, but also something I personally just can't stand, so I mainly use disposable drapes. Now, once the patient is lying down, we use this brown antiseptic solution called betadine. You can see it here. We use this to thoroughly disinfect the surgical site and the patient's whole body. You might ask, wouldn't disinfecting just the incision site be enough? But because we never know where or how contamination might happen, you can think of it as disinfecting almost the entire body. The patient is under general anesthesia, but since they may feel pain at the incision site after they wake up, we also give local anesthesia to the incision area beforehand. And then the surgery begins in earnest. Before the surgery starts, we place this plastic film called Tegaderm on the skin. If I open it up, this is what it looks like. This. Once you peel it open, you can see it's a thin plastic film like this. I'll stick it on my arm to show you. Once it's on, if you remove the paper backing on the outside, only the film stays behind. There can definitely be a difference in scarring between making an incision on bare skin and making one with the skin protected by film, so we perform the surgery with the skin protected like this to some extent. After anesthesia, we make the incision with a scalpel. First, there's the scalpel handle, and then there's the actual scalpel blade we use. Let me show you how this is actually used. When I take it out like this, here's the blade. Now, if you look here, this is the scalpel we actually use, called a number 15 blade. You attach the blade to the handle like this, and then use it in this assembled form. You see? After making an incision with this scalpel, naturally there will be some bleeding. So to stop the bleeding cleanly, we use instruments called a bipolar and a mop for hemostasis. Now, after we've cleanly controlled the bleeding from the blood vessels, like this, we lift the skin with this hook-shaped instrument, and this is a scissor-like tool called Metzenbaum scissors. As we dissect beneath the skin, we work our way down to the muscle called the pectoralis major. Then once we create a passage here, we insert this instrument called a Limburg dissector into that passage and spread it open. As this opens up, it creates enough space for the endoscope to actually go in. Now with it opened like this, we use a retractor. This one is called an army retractor, and when you hold it and look inside, you can see all the muscles in there. That lets us access the area directly, and as we continue opening it downward, we create the working space we need. We go further down and do a bit more dissection to make enough room for the endoscope to enter. Now once we've secured enough space for the endoscope, we don't put it in right away. We first inject a special fluid called tumescent solution. This is usually called hydrodissection. The tumescent solution contains an anesthetic as well as medication that constricts blood vessels, so you can think of it as a solution that helps make the dissection easier. Now if you look here, this clear liquid in the syringe is the actual tumescent solution. If I press this syringe, can you see the fluid coming out like this? This is how we inject the tumescent solution. You can think of it as soaking the fascial tissue with fluid. After injecting the tumescent solution like this, the endoscope actually goes in, and we expand the space as much as needed while dissecting. Now once that space has been secured, the endoscope actually enters through the armpit area, and this instrument here is the endoscope we actually use. An endoscope also has a camera part and a scope part. They come apart, and this is the camera. And this is the scope. This scope part goes inside, and the connected camera captures the images through it. The actual camera model we use is the Striker 1588, which is Striker's top-of-the-line model. To give you a better sense of the camera's resolution, I'll show you. You can even see the palm and the fingerprints on the fingertips very clearly and enlarged. My fingertips are cracked, and if you scrub a lot, that can happen sometimes. Because it magnifies things so much, you can think of it as a tool that helps us perform surgery as safely as possible. Hello, I'm Dr. Kwan Soon-gun. Oh, that's funny. Then, once the dissection is finished, we insert an airbag called a sizer to check whether the space has been made to the size and shape we want. Here, this is an actual sizer, and as you can see, it's shaped like a round pouch. You can inject air into it. Let me actually put some air into it. If I'm going to place a 200 cubic centimeter implant, then I fill a syringe with 200 cubic centimeters of air and inject it. You can see it puffing up as the air goes in, right? After checking whether the dissection was done accurately, whether anything is lacking, and whether the size is right, if the space has been created exactly as intended, we remove the sizer and clean the area again with saline. Of course, it's saline mixed with antibiotics, so it also serves a disinfecting purpose, and you can think of it as washing the inside clean once more to further reduce the risk of infection. Now we're ready to place the actual implant, and I brought a few sample implants here. This one is an implant called Motiva, and this one is an implant called Mentor Extra. As many of you probably know, we don't insert this by hand directly through the armpit. We use a bag called a Keller Funnel, which looks like a piping bag, to insert the implant. A lot of people wonder how an implant this large goes in through such a small incision, so I'll show you a demonstration. Inside this plastic package is the actual Keller Funnel, and when you open it like this, you can see it's made of 2 layers of plastic. Let me open one more. So it's folded up, so let me spread it out. When you take it out and open it up like this, it looks like a piping bag, right? The implant goes into this plastic funnel, but before that, we wet it a little so the implant can slide in smoothly. And if we also wet the actual implant a little and place it inside, then we insert this small opening at the end into the incision and squeeze, and the implant gets pushed out. Let's take a look. Can you see it coming out? This is how the implant actually comes out, and I'll push it through for you. The implant comes out easily, right? So instead of inserting the implant by hand, we use this kind of plastic bag to place the actual implant. This Keller Funnel is made for single use, so of course the rule is to use it once and throw it away, and that's how we use it as well. Once the implant is in place, we close the incision, but we don't stitch the outer skin with thread. Instead, we suture the dermal layer underneath the skin. Using an instrument called a needle holder, along with forceps, we suture the dermal layer under the skin first. If we stitch the skin layer itself with thread, it can leave more scarring, so for the outside we close the incision with a medical skin adhesive called Dermabond. This here is the medical adhesive I'm talking about. There are different brands, so I understand that the type of medical adhesive used can vary from hospital to hospital. When you open it up, this is what it looks like. So when you twist this, the adhesive comes out. I'll put a little on my arm. When I apply it, you can see the liquid here, right? This liquid hardens within seconds, and if the incision stays in that hardened state, then the skin heals in that condition. Usually it stays hardened for about a week, and after that, it dissolves and comes off on its own, so there's no need to remove it separately. So, is the surgery over now? Not yet. After the surgery is finished, I check the design once again and then retape it in that exact shape. The first reason is that after surgery, I personally check once more to make sure it came out exactly as the patient and I originally intended. The second reason is that during follow-up care, if the implant position shifts from that design or the shape changes, I can recognize it right away and correct it. So we go through one more step to set everything as perfectly as possible. Alright, now the surgery is really finished. You've now seen the instruments I use from start to finish in surgery. Has this answered a lot of the questions you had? Breast surgery is a procedure that involves placing an artificial material into the body. To minimize side effects, sterile surgery is the absolute top priority, and of course all of the equipment we use is disposable. When it comes to those things, I never compromise, and I will always do my best to use better equipment and instruments and move in a safer direction so you can undergo surgery without worry. This has been Dr. Kwon Soon-gon. Thank you.